Okay, and hopefully, last but not least, we have one more lecture here on diuretics. Hopefully this one will be quite simple after looking at purpose of administering diuretics is to do the following. To reduce the amount of extracellular fluid to or towards a normal limit. That means to eliminate the formation of edema. Okay, very old very. Look at the data when I took this out of. For best diet, for the best definition I like, 1966. Very old drug. Okay, now to move fluid, you must remember to move electrolytes. You move electrolytes as well. Water follows sodium. Just remember that. Areas that the diuretic effect will have on, we're talking about the kidneys, okay, and what it will do, it will decrease reabsorption of sodium, chloride, water, and other substances. And arteries, we will see some of these may actually cause a direct dilation, decreasing peripheral vascular resistance. In cellular, we can see that there will be some changes that may occur, including with cardiac output as well. So these are the changes that we would like to see actually occur. So, indication for use. Notice the indication for use of a diuretic. Edema, generalized or local. Ascites, okay, that's basically edema happening around your abdominal cavity. Heart failure. We talked about heart failure and reducing the pressure coming out. Hypertension. It is one, and this is where we didn't talk about it with the hypertension medications. It is used for all of these things, so it isn't solely a hypertension medication. It's also used for the treatment of glaucoma, which is a localized, can be a localized increase in pressure in your eyes, specifically intraocular pressure. So that's why we sort of give diuretics. I've gave diuretics its own little lecture separate from hypertensive medications. Now look at these ones here. These. Oh my God! You're going, oh my God! There's 5 more types of medications. Sucks to be you. In seriousness, there are these drugs tell you what they are doing. All you have to remember is the anatomy of the kidneys, and these drugs are very simple. Okay. Thiazide diuretics, loop diuretics. Oh, I wonder what area of the kidney, functional unit of the kidney, this works on. The loop of Henle. Potassium-sparing diuretics. Just remember where potassium is played around with and reabsorbed in the kidneys. That's where this one's working. And then there's things called osmotic diuretics and carbonic anhydrase inhibitors. These 3 are the ones that you should spend the most time on. These ones will probably be 1 or 2 questions on the test, but these 3 right here, 1, 2, and 3, pay attention to those, please. I love this diagram. It's a wonderful diagram. Look at what this diagram does. It tells you where all the medications are working. Okay, we see that we have this one over here. We look, thiazides. Look, thiazides work on the distal convoluted tubule. Is that important? Hell yes. Look what it plays around with. Sodium and chloride. So, thiazide, you always have to think thiazide, DCT, and sodium and chloride. Okay, if we look at this one over here, this spirolactolone, what does it do? Spirolactolone works on the collecting tubule, okay, and the duct, and it is a potassium sparing medication, so it helps with the reabsorption of sodium and the secretion of potassium over here. So as we go through these, look at this diagram, refer back to this diagram when we go through each one of the slides. It's showing you where anatomically all these things are working on. Would I expect you to know this? Yeah, kind of, those 3, I would. So thiazide and thiazide, as we said, acts on the distal convoluted tubule. Okay, it's a synthetic drug. It acts at the diluting segment of the kidney, causes the loss of excretion of urine. So remember, we're trying to move fluid here. So if water follows sodium, guess what this drug does at the distal convoluted tubule? It prevents your kidneys from reabsorbing sodium. Okay, so it's a synthetic drug, causes loss or excretion at the, in the urine, and what it will cause loss and excretion of is water, one, sodium, potassium, magnesium, and chloride. It may artificially increase the level of calcium, glucose, and uric acid, but this is what it does. And look what it is related to, sulfonamides. Oh my God. There's these sulfonamides keep popping up as pain in the ass drugs. These sulfonamides are we talked about in the type 2 diabetes drugs. Oh my God, they cause changes in sensitivity, stimulate your pancreas, and they also screw around with your kidney. So sulfonamides, this is why everybody asks you, do you have a sulfa allergy? Therapeutic effect. Increases excretion of ions and water in the urine. This is important too. You're remembering where these mechanisms of actions work, what electrolyte they are screwing around with. You also better know, important, how fast this drug works. Thiazide, slow onset of action. We're talking hours. Effective only when urine is adequate. So we're talking about people who do not have significant kidney disease. Contraindication. Okay. Nothing good can come of using this drug in patients where rapid diuresis is required. My patient is filling up, they have CHF and their lungs are filling up with fluid and they're going to die very quickly. I do not want to use this drug. It is too slow. Do not use it in anybody with an allergy to sulfonylureas. And do not use in pregnant patients because it will cross over. Uses, look where we can use it from. Management of, long-term management, because it's a slow drug. Long-term management of CHF, hypertension, hepatic cirrhosis, which will lead to ascites, and renal dysfunction. And some of the agents, specifically the specific drug agent names that are thiazide drugs. Look at thiazide, hydrochlorothiazide, chlorothiazide, metrochlorothiazide, thiazide. If it's got a thiazide in it, it belongs to the thiazide type group of drugs. Okay, and know this. And I says know this for testing purposes. Onset around 2 hours. For generally speaking, with these drugs, onset is around 2 hours. Can last up to 6 to 12 hours, depending on which one of these beauty drugs you're taking. Now, this one is a thiazide-like agent. What does it mean? It's a wannabe thiazide, okay? It's related to thiazide. It is essentially does everything exactly the same as thiazide. It just does not chemically look like a thiazide agent, okay? It's also better at clearing creatinine and than thiazide, so it can work a little bit there. Has a little bit quicker onset as well. So this one, you could say if it's not chemically related, then you could say, hey, if you're allergic to thiazide drugs, which is chemically similar to sulfonylureas, then you might want to use this one instead. Now, for all the thiazide and thiazide-like drugs, here are the adverse effects that you'd have. Hypokalemia, so low potassium, which is not good. Remember, we said it could increase calcium, but and it could increase lipids, and it could increase glycemia, and it could also cause high uric acid as well. Okay, but we will see hypokalemia as the major bad effect that we have to worry about. Why? Because it can cause cardiac arrhythmias and muscle weakness. So hypokalemia is the biggest one we need to worry about. And it may produce some metabolic acidosis due to excess secretion of chlorine. Drugs that it interacts with, any sort of glycosides, corticosteroids, NSAIDs, lithium, and also interacts with Questin as well, and some oral anti-diabetic agents. Okay, in particular, especially if it's that thiazide type drug, right? Because it's got sulfonamides in it. So if it's a sulfonamide, it will act like a sulfonylurea in type 2 diabetes, which is why we say oral antidiabetics it will interact with. Doesn't mean you can't give them with these drugs. It means you have to probably use them with caution. Pre-administration implications: allergy, ding, pregnancy, full set of vital signs, electrolytes as well, because we want to see that after giving this drug if there are any major changes, whether or not those changes in electrolytes were there to begin with, or whether or not they were caused by the drug. And we want to look at renal function as well, because you need to have adequate renal output with this drug. You better make sure you have a good creatinine clearance. Post-administration, monitor vital signs, monitor labs, especially potassium. Look for muscle cramping and weakness, because this will show you it's an onset of loss of potassium. Possibly supplement with potassium supplements as well. And this medication is best given early in the morning. Monitor for weight changes, okay, because you want to make sure you're actually moving fluid. And don't drink it with alcohol. Loop diuretics, guess where they're going to work? These work in the most potent of the diabetics that we have. They inhibit the sodium and chloride reabsorption in the ascending limb of the loop of Henle. Prevent sodium reabsorption, okay? And then water follows the salt, so if you don't bring the salt back in, fluid stays in there. This is a very, very potent diuretic agent, more potent than thiazides. This is the one you want to use if you want to actually have somebody diuresed quickly to save their life. Therapeutic effect can cause significant changes, okay? Can cause significant changes in BP, pulmonary vascular resistance, central venous pressure, left and diastolic pressure. Okay, so if you want changes in these significantly quickly, this is the drug for you. Uses: choice of drug when we want rapid diuresis to occur. It's good with elderly patients. It works well on them. It's effective in patients with severely impaired glomerular filtration rate. So here's the two big things right away. Okay. The thiazides, long-term therapy, low and slow is the way to go. Loop diuretics, fast and hard. We want to diurese you quickly. You're in trouble. You've got kidney disease, renal disease happening, which affects your glomerular filtration rate. I want to go with a loop diuretic. So it's used in treatment of heart failure, liver disease, pulmonary edema. Oh, cool. And ascites for rapid treatment of these things. Lasix. This is your Lasix. Okay, loop diuretic Lasix. It's wonderful. You can give it in PO form. It can onset within an hour, peak within 2 hours, duration 2 for 6 hours. If we give it IV, 30 minutes. So this is where we use it when we're trying to save your freaking life. 30 minutes works very well. We also have this other drug here called Bumex, which is used if you're allergic to furosemide. There is an alternative. This is what it looks like. IV form. It can come in a big multi-dose vial, small single-dose vials for IV, and it can come in pill form. And note, yes, I took these pictures off the internet from the Apotex website, and you're wondering, why is he using Apotex website? Is it because is there something subversive here? Is it because they were killed or something like that? Is that why he's putting it up? No. The reason being is this drug is so freaking ass cheap that it's primarily made as a generic drug right now. Okay, and it's called furosemide. Very, very few people call it Lasix anymore. It's made by Sandoz. It's made by Apotex. There's nobody's got a patent on Lasix anymore because it's that freaking old. Loop diuretics, adverse effects, hypokalemia again. So there's another with hypokalemia, hyperglycemia, okay, hypercalcemia, similar, high magnesium, different, and high uric acid, similar to the last one, certainly. Okay, cool. GI, nausea, vomiting, and can cause some diarrhea. We can have some CNS disturbances. High doses can give you a risk for hearing loss, dizziness, headache. You can have tinnitus, which is ringing in the ears, some blurred vision, and some photosensitivity from it. Okay, baseline treatment, BP, edema. We want to assess the edema because we want the edema to get better. So wherever the edema is that you're giving this for, make sure you have a baseline assessment. Labs we want to make sure we have, because it can increase your urea. We want to make sure that you're not already have a high urea going on. We want to know your electrolytes because of the the hyper or the hypos that you can have in it. You want to know your glucose and uric acids, all because of the stuff that was on the previous slide. Implications, monitor for and caution patients against a high sodium diet, monitor for, because you could lose more fluid than you actually want to, you want to monitor for abdominal cramps, alterated urine pattern, diarrhea, blurred vision, and there is in elderly patients, pay attention to, because they're getting older and things ain't working the way they're supposed to, they're at a higher risk for sodium and potassium imbalances. Contraindication. Oh, look, another one that's sulfonamide based. If you have an allergy to sulfonamides, stay away from this drug too. Severe electrolyte imbalances. It can lead you into, if you're in a hepatic coma, you don't want this drug. Amphosoterapin B injectable, you'll find about that drug next semester in pharmacology when then you talk about antibiotics. And warfarin and heparin, do not give it if you're on warfarin or heparin. It can work with that drug as well. And any nephrotoxic medications that you might be on, it's contraindicated as well. Potassium sparing diuretics. I wonder what this does. Mechanism of action. So sodium is usually reabsorbed in the distal collecting tubule in exchange for potassium. So we bring in potassium and we let we bring in sodium, we reabsorb sodium, and we let potassium go out. Okay? Potassium sparing diuretics acts on the distal collective tubule to reduce sodium reabsorption and reduce sodium excretion. So this one, normally potassium is brought back in and usually sodium is brought back in the distal collecting tubule, and in exchange for potassium, and potassium goes out. This medication allows you to actually reduces sodium reabsorption, and water stays with it then, and also prevents excretion of potassium as well. So this is actually a pretty good medication. Okay, so it causes a loss of sodium but not the potassium, and has lower adverse effects because of this. It doesn't screw up your electrolytes as much. It's not potent though. Okay, it's like the thiazide. This one's for long-term use. Okay, it's not a potent diuretic. Use is in combination with other diuretics to offset the loss in potassium. So we use this if our potassium concentration drops below 3.5. We use it in CHF. We use it in patients with hyperaldosteronism. Specifically, they use the drug. This in brackets here is the drug that you use. It's not the other name for hyperaldosteronism. Okay? If you have hyperaldosteronism, the drug of choice is what is in brackets right here, spirolactolone. We use it in pediatric heart failure. I see this drug used all the time in pediatrics. Okay, and we use it in heart failure due to diastolic dysfunction, and we use it for where a patient who has electrolyte imbalances where you want to elevate the potassium and chloride values. So spirolactolone is considered an aldosterone antagonist, and antagonizes the effect of aldosterone in the kidneys, and permits sodium excretion in the distal convoluted tubule. So by interfering with the aldosterone effect in the distal convoluted tubule, you retain your potassium, and that's how that works. Look at the onset, 1 to 3 days. Oh, this is such a long medication. It even takes longer to take effect than thiazide, and the peak usually happens in 2 to 3 days, and its duration lasts about 2 to 3 days. So this is a really long, slow is the way to go. Really long and slow drug. There's another potassium-sparing agent. It's called tiertramine or diurentum. The action of these drugs is it acts independently of aldosterone. Its onset and duration is much quicker than spirolactolone, and it's usually called Mimidor. And look at it actually works. Onset is in 2 hours, peaks in 6 to 10, duration 24. And some adverse effects of this: some cramping, nausea, diarrhea, not bad, dizziness and headache, Guess what? If it's preventing you losing and exchanging potassium for sodium, you can have hyperkalemia, correct. Number one on the hit parade that you might have to know for your test. Some specific adverse events that can actually occur, okay, adverse effects, excuse me, not adverse events. Some specific adverse effects that can happen, risk of gynecomastia in men. That means bigger breasts in men, okay? The tyrosine can induce glucose intolerance. Contraindication if you're hypersensitive to it. If you have severe renal failure, this is not a drug you use with severe renal failure. If you already have a pre-existing hyperkalemia, this drug's just going to make it worse. And tyrosine is used in tyrosine can be used. Tyrosine use in patients with liver failure. Specifically, if you have liver failure, you do not want to use the tyrosine. Prior to BP, look for the edema as well, and look for your labs as well. Specifically, potassium. Post administrations, well, patients should avoid potassium supplements, should avoid any salt substitutes. If you go and look at salt substitutes, meaning your drug saying, hey, it's sodium free. You know why it's sodium free? Because it's got extra potassium in it. So salt substitutes that people may use, basically you get that salty taste from the salt substitute, not because of the sodium, but because of high levels of potassium in it. So this is why you stay away from salt substitutes, because they're like a potassium supplement. And any other food high in potassium. Do routine labs for hyperglycemia, or hyperkalemia. And if hyperkalemia is present, then basically you need to notify an MD and check for any arrhythmias that may occur. And dose again should be taken in the morning. Osmotic diuretics, this is easy. Okay, the hard ones were the last three that we just did. Pay attention very clearly here. These work along the entire nephron. All right, these are large molecules in your blood. What they do is they basically increase the concentration of your bloodstream, and basically draw and basically suck fluid from your interstitial fluid into your vascular space. And then these large molecules are peed out, and the fluid follows these large molecules. That's it. These are medications, specifically mannitol. Okay, these do not affect all your electrolytes, and these medications don't affect sodium excretion as well, because basically these are big molecules your body does not use. Your body does not want to use these at all. You don't break them down. They sit in your bloodstream, they filter through your kidneys, and the fluid has to follow them to filter through. That's it. Okay, they work on osmotic pressure. The use for these are done in emergency cases, okay? These are done for cerebral edema, severe renal failure, glaucoma, where you have high intraocular pressure, and these are used and sometimes for excretion of toxic substances like lithium. Just used for overdose patients as well. So that's pretty much it for osmotic diuretics. Mannitol, all right? Just remember mannitol. Some other agents that they can use is glycerin, there's urea. Mannitol is the big one that we primarily use. You will see adverse effects can cause vomiting, headache. You're going to have volumetric losses from this as well. There are no drug interactions with this medication. Contraindication, you got an allergy to it or severe pulmonary edema. Okay. Carbonic anhydrase inhibitor, these will become, I'm sort of introducing this concept to you, it'll become more evident next semester when you talk about ophthalmic drugs. But these ones screw around with this thing called carbonic anhydrase. Would I most likely put this on a test? No. Look at it, be aware of it, okay? It is a sulfonamide-based drug, primarily used to treat glaucoma, edema, epilepsy, and some high-altitude sickness. This drug you'll worry about a little bit more next semester when we talk about glaucoma drugs. But you need to be aware that this is also a diuretic agent. And the main drugs that we use, that is acetylizam, and like I said, you'll discuss the specific this in semester 3 when we're talking about ophthalmic agents, and I will not directly put this drug on your test and ask specifics about it, because you will deal with it in semester 3, but you need to be aware that it falls into the class of a diuretic agent.